Good evening, everyone. You can hear me, right? Welcome to our research presentation webinar. Today is our second session, and we're going to present you a manuscript of a completed article, which was originally conducted for program fulfillment for an internship program. So I want you to take into consideration the fact that this was something that was done by Dr. Aiden as an intern. And after her graduation, she wanted to work on it further and publish it. And this is what we actually want everybody to do. It's a very good exemplary work that we all should learn from. So she is going to present us on willingness to get COVID-19 vaccine and its determinants among bus drivers in Ethiopia, an institutional-based cross-sectional study. Our reviewer is going to be Dr. Salamon Werku. He's a medical doctor and international MPH holder. He's also a PhD fellow, an expert in the area of health promotion. And I'll be the second reviewer. My name is Tigist. I'm medical doctor, public health specialist, founder and general manager of Medical Research Lounge. And the rest of the review is going to be left for the audience. It's not restricted for the invited reviewers only. So we will take all of your comments into consideration, and we will also give a chance for some of you to ask. So we want you to be attentive and follow everything she presents, because the best place to learn research is actually while seeing, if possible, conducting a research on your own. If not, learning how the others conduct and reach to their conclusion. So it's a very practical opportunity to learn research. I invite you all to participate attentively. So Aidan, you can start presenting. Thank you very much.
Thank you, Dr. Tigist. My title of my thesis is Willingness to Get COVID-19 Vaccine and its Determinant Among Bus Drivers in Ethiopia, an institutional-based cross-sectional study. So coronavirus disease, it's an infectious disease caused by the newly discovered coronavirus. And despite the efforts to decrease the burden of disease through vaccination, COVID-19 vaccine uptake is challenged by vaccine hesitancy and anti-vaccination feeling. So according to World Economic Forum, COVID-19 occupational risk for bus drivers was lower, but their constant exposure with general public put some at risk. So it was intended to study their willingness. So this was a conceptual framework, socio-demographic characteristic and health behavior model like perceived susceptibility and perceived severity and awareness and attitude were said to affect the willingness from previous literature. So the aim of the study was to assess the awareness, attitude, willingness to accept COVID-19 vaccination, and to assess the factors associated with COVID-19 vaccine hesitancy. So the study design was institutional-based cross-sectional design was used, and it was conducted in Shagoli bus station in Addis Ababa from August 16 to October 10, 2021. And Shagoli bus station is one of the largest depot in Addis Ababa, and Ambassa branch had about 400 bus drivers employed at the time of the study. So the inclusion criteria for this were drivers who can read and write, and the exclusion criteria were drivers who were ill at the time of the study. The sampling technique method we used was systematic sampling method. So sample size was calculated using single proportion formula, taking the prevalence rate from previous study for the 3 objectives and using double proportion formula for the 4th objective, and confidence interval of 95 and margin of error 5% was used, and the highest was, after correcting population correction formula, the highest was 195, and it was taken, and non-response rate of 10% was used, and the final sample size was 150. So the operational definition for awareness and it was a knowledge on COVID-19 vaccine gained through education or experience, and attitude were perception or way of thinking on COVID-19 vaccine, and willingness was whether or not the person is willing to accept the vaccine. Can you hear me?
We can hear you, Dr. Aidan. I think you can raise maybe the volume of your PC. It's a bit distant.
Okay. So data measurement, awareness and attitude was assessed by completing by summing up all the relevant awareness and attitude related questions, and correct answer was given score of 1, and incorrect answer was given a score of 0. So overall awareness and attitude was calculated by giving respondents who score greater than the mean value of the sum of these questions were considered having as good awareness and good attitude, and who answered less than the mean value of the sum of this assessment question were considered as having poor awareness and poor attitude. So self-administered questionnaire was prepared, and questions were divided into 4 parts, and it was pre-tested, and data was collected by the principal investigator. Data was entered and managed and analyzed using the statistical SPSS version 23. Median and interquartile range were calculated because Kolmogorov, Smirnov, and Shapiro tests were significant. Percentage ratios were calculated for tabulation and were subjected to chi-square. Binary logistic regression was done, and variables who had p-value less than 0.5 were entered into multivariable binary logistic regression, and significance level was set at p-value of less than 0.05. Good fit model was checked by using Hosmer and Lemonisheau test, and p-value was 0.07 and showed good model fit. So when it comes to the results, 184 respondents answered the questionnaires and making the response rate 85%. So majority of the respondents were from Addis Ababa, and 61% were male. The median age was 30, and when we come to the awareness related questions, 60% had information about the presence of COVID-19 vaccine, and the overall awareness was good in 69.6% of the respondents. So the main source of information about the vaccine was social media, as reported by 44% of the respondents. When it comes to the attitude related questions, so the overall participants' attitude was positive only in 27.2%. So from the 184 participants, only 22 had already taken the vaccine, and only 34.8% reported that they will take the. So the main reason for this hesitancy towards the COVID vaccine was because in 27% answered that they were worried about the possible side effect of the COVID-19 vaccine. So variables who had p-value of 0.25 in bi-variable logistic regression were gender and COVID-19 existence in Ethiopia, and perceived susceptibility and perceived severity, and also those who had close relatives who were affected by COVID-19, and awareness and attitude were entered. So the independent predictors were found to be perceived susceptibility and perceived severity. Also respondents who believed that they were at higher risk of being infected with COVID-19 was 3 times more than those who didn't think that they were susceptible. So similarly, the also of who perceived as for severity were 2.7 times higher. So the odds were 2.7 times more than those who didn't. So on discussion, the level of awareness in the study was 69.6. This is similar to study done in Guaraghi Zone, Ethiopia, and it's higher than a mixed method study done in Addis Ababa. So also the positive attitude was 0.7%. This is lower than other studies done in Guaraghi Zone and in Addis Ababa. This could be because the main source of information reported in the study was social media, which would be filled with misinformation. And the vaccination coverage was low, and level of willingness was 34.8. This is similar to e-survey done in Addis Ababa, but it's much lower than study done in Walaita Sodo and Addis Ababa again, and in Guaraghi Zone. So again, the discrepancy could be because of the difference in socio-demographic characteristic in the study area and the main source of information. The other is the significant predictors for willingness were perceived susceptibility and perceived severity. This is similar to study done in USA, and also negative attitude had significantly decreased showed significantly decreased willingness. This is similar to a study done in Addis Ababa. So the strength of the study is because it was done in bus drivers, and which where there was a gap in this area. So the limitation could be it was self-administered questionnaire and subjected to difference in understanding and interpretation. Reliability test was not assessed for awareness and attitude questions. So in conclusion, the level of willingness is very low compared to other literatures, which was not enough to achieve herd immunity. And it's also alarming because the study is done in risk groups such as bus drivers, and respondents' willingness were significantly associated with their attitude, belief that the high risk of being infected and possibility of being susceptible to severe COVID-19 infection. So the media can use social media and should focus on creating content that emphasizes on educating about the risk and severity of COVID-19 vaccine, and healthcare planners should also create relevant programs for providing trusted information to improve attitude towards the vaccine. So thank you.
Thank you, Dr. Aidan, for your nice presentation and for making sure to finish on time. This will give us ample time for discussion. Thank you very much. So now Dr. Solomon will start with his comments and suggestions. Dr. Solomon, it's very nice to have you here today. He's an expert in the field. You cannot, I cannot think of a better person to review this paper. And we're glad to have you. Thank you very much for joining us today. So you can start forwarding your suggestions and comments.
Thank you so much, Dr. Tigist. I think it's good to to show people who I am, just in case, because so that now you can connect with my face with whatever I'll be saying. Having said that, since I have a very limited connection, I'm gonna put up the video, if that is okay.
Sounds great.
Wonderful. Thank you, Dr. Aidan, for a wonderful work. I think this is and I see even without having a master's in public health, you seem to be doing a very wonderful job. And I've been advising on a lot of master's paper, but they're not as quality at this paper. And I'm so happy and proud of you. And I hope that you're gonna make a very good researcher. If you can produce such work at this time in your career, then for sure, and after having plenty of training, you'll be making a great researcher. Having said that, whatever paper that you come up with, whatever research work, it's always open for critic. Even you find papers in Lancet, BMJ, it's likely that they can be they can be easily critiqued. You know, there is nothing as easy as critiquing a paper. You know, so taking that into account, whatever I say is not going to be some of the things that you would be changing, but most of the things you probably it's not easy for you to go back and make change. So since this platform is a learning forum, it's just like a postmortem for me. So if we ever do such kind of study, what would be this best approach that we're going to do? So that I'll be focusing on that area, that opposed to directly providing feedback for Aiden. So this is going to be for every one of us on this platform to learn if we do any research in the future. Okay, with that notion, I'll be making my comment. First one is the rationale, why you want to do the study. I think you seem to be very clear about why you want to do the study. These are group of individuals. The bus drivers are, people who are at the most at risk, not only acquiring infection with themselves, but they're gonna give it to other people when providing service. So targeting those particular group of individuals is important, and I'm so happy that you targeted the right people when it comes to COVID alleviating the risk of COVID acquisition in the future. So in terms of significance, you would have said a little more in your paper about how the finding is going to be useful. So what do we do with this finding? I think in the conclusion, you seem to be mentioning that, but you'd have also said a little bit on the background why you want to do the study and its significance. So who do you want to act on this finding? What do you want to come out of this whole finding? Then you would have said a few lines, like 2-3 lines, so that people will know the relevance of your study. You've mentioned the rationale, what you want to do the study, but another important thing in any research is, so what? So what would you want to happen as a result of this finding? So I know it's a manuscript. You prepare it in a way that is going to be published, or even if in a manuscript, that I still suggest on the introduction at the last line that you would mention who's going to benefit from this finding and how it's going to be used, and we call that a significance. So I don't think this is going to be a back and forth kind of session. I'm going to forward my feedback. So some of it, if you already know it, you just take it as it is. If it's not making sense to you, you can drop it. It's okay. So if it was a live session, I would have asked you, what was your hypothesis? What do you, okay? When you, as a researcher, what were you expecting to see? Okay. Every researcher needs to have a bit of a notion while conducting a study. You need to have something in mind, okay? So what is the problem with the willingness? Why do you expect that people would not be willing to take the vaccine? All right. So you see, I'm so happy that you brought up a model, which is a health belief model. That's a wonderful thing. Yes, it's wonderful. So you seem to be indicating 3 of the constructs in the health belief model: the susceptibility, severity, which are both the threats, but I would also expect to exhaust all the models. In the model, you probably would see the benefit. I think the effectiveness is the benefit for you, I guess. But you could also indicate the barrier, all right? The barrier could also be an important thing that you need to look at, and the benefits. So that would complete the whole health belief model, as opposed to picking some of it. Okay, and I'm so happy that you've already picked the model. But if you decide to use the model to guide you in answering your research question, the best would be in exhausting everything in the model. So susceptibility, severity is wonderful. And then effectiveness, if it is for the benefit, I agree, the benefit. And the fourth and the most important one is also the barrier. All right. And another important thing that you probably missed in this model is efficacy, self-efficacy. You know, some of the reasons that people might not be interested or willing to take the vaccine could be they might think that this is not something for them. They're bus drivers. They feel like this is something that they deserve to take because of many reasons, because of their socioeconomic conditions or whatever. And they think that this could be something fancy that probably healthcare providers need to take, not the bus drivers. Or they feel that this could also go with the motivation. Okay, when you talk about efficacy, self-efficacy, it's about the confidence, the belief on taking the vaccine. Now, they might say that this is not something for me. So another thing that you probably need to look at is self-efficacy. So three things that you missed in the model: self-efficacy, benefit, and barriers. If you would have included all these three, this would have been complete. So now you don't have to worry. This is an academic session. So if you do this again, if anybody is interested to do this again, I recommend that once you decide to use a model, it has to be comprehensive. Use every construct that is outlined in the model. That is my third comment. The fourth is about the objective. I think, and I recommend that you stick with the title, willingness. Okay, to assess. I would have stick with to assess the willingness to accept COVID, because the awareness and attitude are also the determinants in your case that that dictates whether the drivers are willing to accept the vaccine or not. Okay, why are not they willing? They're not willing because they're not aware of it or they're not knowledgeable. Why are not they willing? They probably don't have a positive attitude towards it. So the awareness and the attitude could fall under the factors that determine whether they're willing or not to receive the vaccine. So I would have changed this title into, for example, to assess the willingness to accept COVID vaccine and the determinants. And then if you say that, the determinants, there you go. You have the awareness and the attitude as well. So otherwise, if you want to keep this objective, I would expect you to examine every factor that determine the knowledge, every factor that determine the attitude, which I don't think that you have exhausted all this in your study. So this probably need a bit of review as well. So, and the other thing is that your objective would be very specific. Okay, this is not a very specific objective. It tries to look at everything to assess the awareness, the attitude, and the willingness. There are too many variables that you need to look at. And for me, your most important outcome variable here is the willingness. Okay, yes or no. I'm interested to take the vaccine if I ever get it. I'm not interested to take the vaccine, even if it's available. So these are dichotomous, and these are the outcome variables or the dependent variables that you're interested to see. So that would make everything easy in your study if it is specific. My fifth comment is on the design. Okay, you picked a cross-sectional study, which is okay. You calculated in a very scientific way the sample size. But in your study, the participants are, the population, not the study, the whole population in your study is about 1,300. Yes, 1,300, I think. These are the staff in the institution, in your study, in the study area, I guess. Okay, and out of this 1,300, I think 400 are the bus drivers. But I'm not sure if everyone in your study are bus drivers, because the domain seems for me, the denominator seems to me, every staff in Shagole bus station, which includes the HR people, the inspectors. So 1,300 is that everybody in this institution, and out of this, 400 bus drivers, but in your study, I don't know how many are actually the bus drivers, because you want to look at everyone, okay? And then how you sample out of this. If you sample out of 1,300, 400, I don't think all the participants in the study are bus drivers. If that is the case, if you pick the study participants out of the 400 bus drivers, the 215 are out of the 400, that will make about 50%. So you don't have to even calculate, all this fancy sample size calculation for me, because you already take half of them, which is okay for me. So you probably would clarify that later. And the second is the sampling technique. You said, okay, so you have the denominator is 400. So you picked 195, which is about 50%. So, I mean, Tegus is also a very good in the stats. She would comment on this later. But for me, should you have to go all this through calculation, to pick half of them? And the sampling technique is a systematic sampling technique. I don't know how that is systematized in a way. And have you taken what is the aim? Did you take the participants like every 3, every 4? That's how we don't know. How did you pick the first individual in the study? This is something that you need to think about as well. All right. So the other one is the inclusion criteria. You've mentioned the inclusion literacy, and I was imagining that, is there anyone who is not literate in that particular institution which you want to exclude it? And besides, should literacy be a reason to exclude someone from the study? Because I don't know, let's assume that there are illiterate drivers in this particular institutions. For me, they're equally important to be part of the study. You need to find a way to engage them. It could be through interview questionnaire. I think it's a self-administered questionnaire. But if I were you, and if I still see that there are drivers who are illiterate, which I'm not sure if there are any illiterate drivers, if there are any, because they're also important in the study, because literacy could also impact your finding. Literacy could impact the willingness to take a vaccine. So one of the things that, if I were you, would be interested to look at it, how it is like when it comes to literacy. So I don't think that should be an important criteria to exclude participants. We don't have to exclude them because they don't read and write, even though they're the kind of people that we need to be interested to look at. When it comes to willingness, when it comes to something that require knowledge. So if I don't think they're going to go back and redo this, but this is, for every one of us in this room who could benefit from this discussion. So in terms of sequencing, putting following the format, it needs revisiting. Sometimes you put the sample size calculation before usually you need to bring sampling technique after sample size calculation and stuff like that. This might not be very important, but sequence is important. Definition, or 6th comment as definition. What does operational definition mean? This is for every one of us. When you say operational, it means that you make it, you put the definition in a way that is relevant to your study. It's not definite, it's an operational definition. What are you operationalizing it? So you operationalize it in a way that fits into your study. Okay, you make change to suit to your study. That's what operational definition means. When you look at these definitions, there is nothing that you actually operationalized. What does awareness means? Knowledge about COVID gained through education. Okay, this is not an operational definition. The awareness is, of course, knowledge that someone acquired through education or experience. Okay, attitude is perception. That's it. So it becomes an operational definition. For example, if we say, for me, I would say awareness on COVID vaccine when someone scores 60% and above on a validated awareness questionnaire on COVID vaccine. Okay. Attitude is, for me, I would say favorable attitude is someone scores 60% and above on the attitude questions that are listed here. Okay. That is what's called operational leverage. These are not operational leverage. I think the second one, the one that you mentioned later, is, for me, seems more operational, I guess, in your study, which is awareness, and I was assessed using but the scoring, if you mention anything, the mean value, respondents who score greater than a mean value was considered having a good. This is an operational definition for me. That's not data measurement. This is an operational definition. And the other important thing for every one of us in this room is, when you put a cutoff point and use mean, it means that you're comparing individuals among themselves. So to say they have better, those who score above the mean have got good knowledge. If we say so, the finding would entirely be different if you pick another group of study participants. Okay, because you use the mean, you comparing among themselves. So if you select a different sample, you would entirely get something different. So usually we don't recommend for you to use mean, to use that as a cutoff point. At least median could be better even. But I'm suggesting one of the flaws in your study is that for you to decide whether someone has a good attitude or not, or a good awareness or not, you haven't used a validated tool. You came up with list of 4 questions for you to say someone is good awareness and some has good attitude or not. Those are few questions for you to declare someone has got good knowledge and someone has good attitude. So it requires validity becomes an issue here. How can you decide for someone to be knowledgeable because he answered? Even that's not about knowledge, it's about awareness. Have you been, the questions when you look at them are not testing any awareness. They say, did you receive any information on this? Did you receive information on this? These are the kind of things that you've asked them. And then you ask 4 questions and declare whether they are aware or not. So I think validity is one of the most important limitations in your study. Next time you do similar studies, what I'm recommending is make sure that you use a validated items that are tested everywhere for you to declare someone is knowledgeable or not. If you look at the resource, I think on the web, you could find a lot of studies on COVID knowledge or attitude. That there are plenty of items listed that can guide you, for you to declare someone is knowledgeable or not. And you bring it here. I'm not saying that you're going to use the tool as it is, but bring the validated tool and test it here, pretest it here, and make amendments. Okay. And the other one is, okay, now I've already mentioned about the awareness. Mean, the questions on knowledge and attitude, and analysis. And analysis, you've said median, interquartile, range, ratio are used, but I haven't seen in your study. I think median is only used in the income, but I haven't seen anywhere else. And interquartile, range, ratio, I haven't seen them in your study. It's okay. The other is, for me, the most important measure of association you used is odds ratio. It seems that you've used chi-squares analysis, but I was imagining that you use chi-square only to test for goodness of fit, I guess. Goodness of fit to check for model adequacy, I think. Is that not true? Maybe you respond for this later. Otherwise, you haven't used chi-square for your analysis. You use odds ratio as a measure of association in your study, and chi-square is used only to test for goodness of fit, I think. No. Goodness of fit test. And I would also, maybe in the analysis, I don't want to preempt the session. Maybe Dr. Tickes would say for sure more on the analysis, because she's authority on the area and she's very passionate about it. for sure should be also commenting on and how the other assumptions that you should have made, like multicollinearity and other important assumptions that you need to consider in the study for using the multivariable binary regression model. Ethics, how are the study participants going to benefit from the study? You haven't mentioned anything about it. It's very important, by the way, as a researcher. It's not enough that you assure privacy, confidentiality. No. You need also to think about, so what are those people directly benefit from your study? That has to be indicated in your ethics as well. Result, I think I have already mentioned some of them earlier, that you could have exhausted all the variables, all the construct in health belief model, including the benefit, efficacy, and barriers. The other one is you didn't consider all the other social demographic variables in the regression table. You only took gender. How about education, age? Don't you think these are important social demographic variables that could also affect the willingness to take the vaccine or not? But I'm expect that those who are better educated, I would imagine, those who are older because of their age and that put them at risk would be willing to take the vaccine. So I think those are an important social demographic variable that you should have brought into the analysis. So that you could compare whether they are willing or not. I'm saying education, age, and other social demographic variables that we've mentioned earlier. Another important observation that I make is you have asked them, do you have information about COVID vaccine? And those who said yes are 111, and those who say no are 42, about 42% maybe. So this would tell us that, almost 40% of the individuals and the bus drivers don't know even COVID vaccine exists. And this is huge for me. This is huge. So for me, this is an area also that you need to discuss very well. Okay, so the next discussion should be about only the 111 who said that they have information about COVID vaccine. Okay. So if you ask effectiveness, it should be that 111, nobody else. If you're asking about the willingness, it should be the 111. Okay, not the other ones. But it seems that ሁሉንም ሳየው እንዳለ 184ቱም አሉ. I don't understand that because once someone said that I don't know about whether COVID vaccine exists or not, ካለ በኋላ I'm not going to ask this same individual that do you know that COVID vaccine is effective? It doesn't make sense because he already doesn't know that COVID vaccine exists or not. So I'm not going to ask him whether it's effective or not. Or I'm not also supposed to ask him whether he's willing or not, because he already said that he doesn't know the vaccine exists. I only ask individuals who know whether there is a vaccine, that whether they're willing to take it or not. How can you ask someone who already doesn't know whether it exists or whether he's willing to take it or not? Because it's the first time that you're telling him that there is a vaccine, and then immediately if you ask him whether he's willing to take it or not, it doesn't make sense. So another important flaw, I don't know if I misunderstood you or not, you probably would explain that, but everything else that refers to the willingness has to be those individuals who've already informed up, already know that there is a vaccine. But that is an important observation that I make. Another thing is in a table 5, the reason for hesitancy, about 14% are others. This is the third biggest percentage. Okay, so when you find, this is for the rest of you attending, if you put your data on a table, and if you have a huge percentage which says others, it has to be explained at the bottom. What does this others mean? You see, 26%. The frequency is huge, it's big, so it has to be explained. Okay, what does that mean? This should be important reasons listed here that people are interested to know. Okay, so this is something that you don't have to overlook. All right. So for me, your key finding is the perceived severity and perceived susceptibility actually determine whether an individual is willing to take the vaccine or not, which is a very good one. So I think it might not be that new. That's everywhere for individuals to act on a particular behavior. It could be vaccine or whatever testing. You know, people need to feel that they have the risk. They need to feel that if they acquire the disease, it is severe. So it might not be a new finding, but it's good that you come up with some evidence to show at this. Maybe my last point could be about the discussion. The discussion is not comparison, okay? If discussion is about making sense of data, it's an interpretation. It's about giving meaning to your finding. What does it mean to you? Okay, what does it mean to you? Low means, okay? That is what you need to discuss. Okay. Next, I've seen reviewing lots of papers, and everybody, when the discussion part, people indicate that what other studies are saying. No, it's not enough. What other is, of course, it's important that you mention what other studies are saying, but beyond that, it's important that you mention what it means. It's about interpretation. It's about making sense of your data. Now you have a result. Now you have a finding that you give meaning to your finding. Okay. So I wish I would have seen more of that in your study, but I'm not saying these are not important. So you've mentioned that there are limitations, but the limitation that you've mentioned there could be some information bias because of your tool. That's right. In your recommendations, again, you can never finish everything. Your study will never solve every problem on the planet. So what you need to do as a researcher is suggest further studies, identify areas that you haven't explored, and tell people to study on it. Okay, that is for me the best recommendation is recommending, identifying some areas which is still confusing, which is not very clear for you, which you still miss to explore further, and then you recommend for the researchers to look at. Okay, that is the best recommendation. Trust me, I recommend. Okay. Maybe another important thing that you probably, I think Tigist would also mention this about your analysis. I wish I would have seen what association that you've looked at earlier while calculating for cross-odds ratio, that again, that you happen to find some confounders that are removed when you adjust. That is something that I would have loved to look at, so that we know which variables are an association, a strong association on your initial analysis in a binary regression when you calculate the cross-odds ratio, and later the association disappear when you adjust, so that you know which variables are confounders. It's also another important thing that you need to look at. I think I don't have to say more. I think that I've taken more time. Sorry. Over to you, Dr. Tigist.
Thank you, Dr. Salamon. This platform is actually for discussion and learning from each other. So you can even take more than this, because in a normal school setup, students are usually like nervous, frustrated, and they don't even listen to the comments that are forwarded. And there is usually like no audience or very few audience to learn from that experience. So it's we can take as much time as we can so that the audience and the reviewers can reflect their ideas. And thank you so much, Dr. Salamon. As my mentor, I have learned a lot from you, and my learning still continues, and I'm very impressed with the comments you have forwarded. I'm sure we all have learned something new. Dr. Eden, at the end of our suggestions, you can reflect on few of the things. You are not expected to provide an answer like for each and every question, okay? And we will also forward the participants' comments at the end. Thank you, Dr. Salamon, once again. So I'll forward a few suggestions because most of them are addressed by Dr. Salamon. So let's start with the title, Dr. Aidan. We can go, let's go to that slide, please. So as you can see, on the title, it says willingness to get COVID-19 vaccine and its determinants. Is there anyone who'd like to suggest something, especially if you have attended session 1, you know what my concern is on the title. I have like a concern with the use of the word determinants. As being a cross-sectional study design, we tend to reserve some terminologies for some type of study design and others for other study design. It's an indirect way of communicating the strings of evidence that we generate from the study that we have conducted. So for cross-sectional and case control studies, because of the nature of the data we collect and the measure of association that we get, we tend to use the word associated factors instead of just determinants, predictors, prognostic factors, risk factors. These are actually terms that we reserve for follow-up studies like cohorts or for experimental studies where the strength of evidence that we get is a bit more strong, and we can be comfortable enough to say that there is a potential risk factor or determinant or predictors or prognostic factors or even impact effect, these terminologies. So as you go high up in the pyramid of study design, you can use those terms, but not for cross-sectional study and not for case control study. So it should be avoided. The other is your study is conducted in one area, in one specific area in Addis. So instead of saying in Ethiopia, it's better to say in Addis Ababa. I know for our international readers, if you say Addis Ababa, most people might not know where Addis Ababa is. So you can at least contextualize it by saying among bus drivers in a large city in Ethiopia or something like that, so that it can reflect that you have actually conducted a study in one specific area. So when we go to the rationale of the study, anybody who can read the title can automatically understand the rationale of the study. This is a profession where there is a high risk of contamination, given our setup especially. So these are very key population groups to be studied, and we want them to be vaccinated. We want them to be willing to get vaccinated. So you should show that rationale clearly. We just assume that because we know that there are high-risk groups, but you did not explain it very well. You rather put the rationale on the study area. It should not be there. Rather, you should bring it to the rationale of the study, which is like somewhere before your objective on the introduction section. So you should bring it there. On the objective, I think you have put the general objective. Dr. Salamon also reflected on it. Just to add a few things, the ultimate goal of in any CAP study, when we study knowledge, attitude, and practice of a given condition among some population groups, the rationale is, we want people to have a good practice toward that subject matter. So assessing the knowledge and the attitude is eventually to make sure that our study population has a good practice. So if you are going to study willingness, attitude, and awareness separately, you have to have 3 inferential objectives to address all the factors, and you have to do 3 regression analysis. So besides, it's not relevant since the ultimate goal is to get them into a good practice behavior. Just stick to the willingness and drop the awareness and attitude from your objective as well, so that they can be addressed as exposure variables, which is actually what you did. The only problem is the way you state the objective, which doesn't reflect what you did. So revise it like that. On the eligibility criteria, you have said that you have included only those who can read and write. This, in addition to the concern Dr. Salamon raised, This became a problem when you decide to collect the data using a self-administered tool. Why didn't you use an interviewer-administered tool? I mean, some of the questions you have also mentioned as a limitation that since it's a self-administered questionnaire, some of the questions might be vulnerable for like personal interpretation. So to avoid that and to make sure that everyone is included, it would have been better if you have used an interviewer administered questionnaire. Besides excluding this group of participants means, I mean, we know that with better education comes better knowledge about a given subject matter and better attitude and better practice. So if you avoid this group of participants who cannot read and write and who we believe to be highly likely to reject or not to accept the vaccine, then it will not represent the entire study population. Their willingness, the sum up score that you get might not represent the source population that you have studied. So it could have been avoided just like that. And for the exclusion criteria, you said that those who were ill at the time of the study. This is something, by the way, that you get in every paper. So Dr. Eden, I want you to reflect this now. Did you really get critically ill bus drivers at the time of the study at the bus station? Did you? Just this question. I know we're not going to make it like a dialogue, but I want to know if you have encountered that kind of patient during your study time. Did you?
No.
Yeah. I mean, if there's a bus driver who's ill, who can't give data to the extent that he can't even give data, I mean, or respond to a questionnaire, what is he doing at workplace, right? This is not a hospital, right? So the only place that makes sense to mention this as an exclusion criteria is in a hospital setup, especially in an emergency setup or ICU, even in a stable ward or in an outpatient department. We don't expect this. The other is we should revise our methodology based on the actual findings that we have. I mean, for the sake of writing your proposal, you might assume some exclusion criteria, but after you conduct the study, you might not encounter every exclusion criteria. So you should remove that. So now you're saying I have excluded this type of patients. So make sure to write only the things that you have actually encountered, and you have to remove the things that you have initially assumed while writing your proposal. So the other is your sampling technique. You said you have used systematic sampling method. It should actually come after the sample size calculation, but it's all right. So if you use systematic sampling method, you should put the method that you have used, the interval and other things that you should have explained. So we can skip it. This is something minor comments on the operational definition. Dr. Solomon, I think before that we have the sample size. So for the sample size, for the sample size calculation, you have used, for the single population proportion formula, you have used the 3 p-values to address, I think, all the knowledge, attitude, and willingness, right? So you have the type of study that you have extracted these p-values is not clear. Is it in a comparable population, or is it on just a general population, or what kind of population group was these studies conducted on? Is it relatable? And the other is you did great because you have 3 outcomes that you have initially planned, but you have actually conducted the study with 1 outcome only. So you can stick to one of the sample sizes from the 3. But if you have 3 outcomes, you have to run the sample size calculation for all the 3 outcomes. So this should be again reflected on your double population proportion formula on the next slide. Please go to the next slide. So on your double population proportion formula, you say for the objective, you have calculated only 1 sample size, but you don't have a for the objective. It's not just for the objective. If you are going to count all the 3 variables as an outcome, then you will have 6 objectives, 3 descriptive, 3 inferential for each outcome, right? So you will have to determine the prevalence of or the prevalence of good the prevalence of positive attitude among the participants to identify factors that affect the attitude. So just like this, you will have two objectives for each outcome. So a total of 6 objectives, 3 descriptive, 3 inferential objectives. So you'll be expected to do the same here. So you have to calculate double population for all the 3 inferential objectives. Since we have agreed that it's not necessary to consider awareness and attitude as an outcome, you can drop that for both the single population and the double population formula. So back to the audience, what is the rationale of using double population formula for this research? So she has used 2 different types of formula, single population proportion formula and double population proportion formula. So what's the rationale? Let me give you 30 seconds and drop your answers. So what is the relevance of using single population formula? What can be achieved with that, and what can be achieved with the double population proportion formula? Anybody who's working on a cross-sectional study, maybe? Right, so yes, the single population proportion formula is to calculate sample size to answer her descriptive objective, which is the objective to measure the level of willingness among the participants. That is, yes, great. For the prevalence of willingness, we use the single population proportion formula. For the inferential objective or the analytic objective, which is to identify factors that affect the willingness of COVID-19 vaccine among the participants, since this is since she's looking for factors that could determine the outcome, there is an internally to population, like based on gender, male would be compared with female, based on age, one age group will be compared with another age group, and just like that, for all variables, there will be internally 2 groups that we compare when we do our analysis. So to answer that inferential objective, we need to calculate a sample size which has power. In the single population proportion formula, we don't have power. We only we only consider the type 1 error alpha, but in double population proportion formula, we consider not only the type 1 error, but also the type 2 error. So since we're going to consider power, the result that we get, we can comfortably say with what power is the degree of relationship acceptable. So double population proportion formula is calculated because she has an inferential objective. So this is the only place where we run 2 different types of sample sizes, but for the rest, other than cross-sectional study, case control, cohort, and others, since they are like basically inferential analytic studies, they don't have a descriptive version. They only have 1 sample size calculation formula, which already has power in it. So we can feel comfortable by calculating just 1 sample size with 1 formula. So to continue with the operational definition, Dr. Solomon has explained it very well. The most important thing is just avoid the normal definitions, and you have to, all you are expected to show is to say is like, I have assessed awareness using this standard tool. It has this many questions, and from these questions, we have got, based on this cutoff point, we will say that the patient is willing or, knowledgeable or not knowledgeable, favorable, unfavorable attitude. So I don't think you have used a standard tool. You have referenced some articles which are not standard, but it's very important to use standard or validated tool, because we're going to use your result for intervention, and we want our intervention to be based on some acceptable standard tool. When we don't have a standard tool, we can do some pretest and contextualizing in our setup, and the least we can do is, after we collect the data, what can we do to assess the internal reliability of the study? Back to the audience, please drop your question. So she did not use a standard question tool, and she didn't have time to do validity test for her study because it was an internship paper. If it was like a PhD program, she could have done standardization of the tool first, and then she can conduct the study. But if that's not the case, after you collect your data, there is still a chance to do something. And yes, pre-test, pilot test, study, yes, still these are not yes. Thank you, Tina. So what we can do is after she collect the data, she can at least assess internal consistency or reliability of the tool by calculating the Cronbach's alpha. So you can still do this. So it's a good news. You can run that and see if it is internally reliable or not. So this is something that you can do. And using the mean cutoff point, that's usually a thing that people dive into, but it's not acceptable. It's like, you know, for my students, the best example that I give is, if you say that the pass mark is like mean, that means like 50, do you think the school will accept 50 is like failed, right? For a master's, or I don't know, postgraduate, even undergraduate program, right? So we're saying that someone has a good knowledge after getting a mean score, which is not acceptable. Instead, if you don't get a reasonable, when we talk about operational definition of tools like knowledge, attitude, practice, things that are measured with a number of questions, the big problem is not only getting standard questions. The second problem is summarizing those questions into one value and labeling it and classifying it. So the classification by itself needs a standard reference. Using 50%, 75%, 80% should be backed by a standard reference or guideline. So if we can't do that, what can we do? What's our second option? I mean, if there is no standard cutoff point that we can use, something that's reliable, what's our option? Back to the audience. So if you don't have any cutoff point, mean or median, great. So yeah, I mean, instead of just using the mean or the median, so let's say she's using knowledge as an outcome. She has calculated the values. She has a summed up score. So classifying it is causing a problem because we don't have a standard reference. So what's the other option we can do to run our regression? Percentage, great. So percentage means, yes, like we're not supposed to treat every data as a categorical variable, right? We know that categorizing variables will give us more meaning as a clinician or as someone in any field. You know, instead of just putting numbers, we'd feel more comfortable when we say that, you know, the knowledge is good, adequate, inadequate, attitude is favorable, unfavorable. When we come to the clinical practice, you know, the lab values are high, low, BP is like stage 1, stage 2. This makes sense because we can intervene. But when that cutoff point is not acceptable or standard, the damage we're going to cause is more. So instead of classifying it, we can use it as a number, as it is. We can convert it into percentage and we can use it as a number. So in that case, we can use a different regression model called linear regression model. So this will save us the trouble, at least by half, when we don't use a standard reference. So that should be considered. The other is on your variable list, you have used, you have just say like comorbid illness, yes, no. How about the type of comorbid illness? Did you collect data on that? It's very important to see their willingness based on their comorbid illness. And I mean, detailed information would have been important because it's a very critical issue. It's what makes them high risk and what makes them to have better knowledge or willingness towards COVID-19 vaccine. And the other is the vaccine eligibility criteria is also important. You have conducted this study as an how many years back was it, Dr. Aidan? Dr. Aidan?
It was 2 years back.
2 years back. So by then, was the vaccine available for everyone? It was just available like based on some eligibility criteria, right?
Yes.
So this is a very critical issue because if at that time the vaccine is not available for everyone, I think bus drivers are high risk. So was it available for them like universally? If you're a bus driver, you get the vaccine. Was the criteria like that at the moment?
I didn't check it specifically.
Yeah, it's very important because their eligibility by itself causes a big difference. I'll talk about it on the result section. So on the data collection tool, I think it's by mistake, I guess you said interviews were used to collect the data. So you have only used the self-administered questionnaire. That should be corrected. And on the data quality assurance, there is nothing literally. So what did you do to assure the quality of the data? There are so many things that should be addressed, and you should go back and revise what you have done in terms of keeping the quality of the data, in terms of training the data collectors, and other things should be further be considered. On the data analysis plan, you've mentioned that median, can you go to the next slide, please? You've mentioned that you have used median with interquartile range, but I think the audience would benefit more if you specify for what type of variables you have used the specific type of summary measures. So I think it should be stated like for numeric variables, we have used median with interquartile range because of their skewed nature after testing it with some sort of normality test. And for for categorical variables, we have used frequency with percentage because that's what you have used. So without mentioning the nature of the variable, when you just say median, interquartile range, percentage, it might be a bit confusing for the audience. And the other is you did not use ratio or cross tabulation and chi-square test in your thesis throughout the report. I was trying to see for that. So you did not use those things, and you shouldn't put that, especially ratio. There is nothing that you have used, so it should be removed. So let's go to the here. You did a great thing. You've assessed the model fitness. You have used Hosmer-Lemshow test, which is very nice. Let's go to the results section. On the results section, your response rate was 85%. So she started with a non-response rate in her sample size calculation. She has considered a non-response rate of 10%, but now she has a non-response rate of 15%. So do you think this is acceptable? So the initial, let me remind you, and the initial sample size she has calculated was 195. And thereafter, after adding 10% non-response rate, she has got 215, and in finite population correction was done. So now, when we add 10% non-response or any sort of percentage of non-response rate, the assumption is, so for your study, to meet your study objective, you need the minimum sample size you need is 195. So since we don't want to take that risk because there is a chance that people might not respond to our study, or we might miss the questionnaire, or after even we collect the data, some questionnaires might have some problems and we might be forced to reject them. So since there will be some sort of inconvenience in any study, we don't want to go with just the calculated sample size. So what we do is, to avoid those inconveniences, we add some contingency. So in a non-sensitive topic, in a primary data collection, well, the rule of thumb is like 10%, because usually like even less than 5% will be our non-response. That's from the common trend. So, but in your case, there is a 15% non-response. So this is, there is two problems here. One is actually question, how come 15% non-response rate? I mean, what was the reason for the non-response rates? This is a primary data collection, not a sensitive topic. Why that much non-response rate? And the other is you are down by like 10 from your 11 from your original minimum sample size requirement. So this will cause a problem in your generalization of your result. Because to generalize your result, you need a minimum of 195, but you have got only 184. So this is an issue. And the other is, just to go back to the sample size calculation, I wanted to cover it here, that's why I skipped. Adjusting for finite population correction should not be a mandatory thing to do. I think I see a senior statistician in the meeting. If he's still in the meeting, I'll give him a chance for, later to add on this. So finite population correction is a concept which is there to make sure that we utilize our resource properly and to avoid unnecessary participant engagement in a study when our total population size is small. So you did the right thing, but when our sample size, if our sample size gets very low after correction, and you know, so when you before you correct it, it was like 200 something. So when you correct it, it becomes 195. So instead of using the 195, I'd suggest using the 230 or 40 something, because with this small sample size with 184, there's a high chance for a small frequency, issue of a small frequency in your data, which might result in inconclusive results because of wide confidence intervals. So instead of risking this, it's better to avoid the finite population correction and use the entire, the original study sample size population, because it's like, you know, the rationale, as I say this, if you can reach to a if 100 population is a good representative for 5,000 source population, then you shouldn't take the 150 patients you have originally calculated and come up with the normal sample size calculation. But just for the sake of avoiding further trouble for the 50 additional participants, and if we use the 100 participants for our analysis, and if that analysis doesn't give us a good meaning, so what we end up doing is hurting 100 more patients by including them in a study, which is not going to bring any change. So instead of doing that, we have to balance, we have to judge and add extra 50, which was which we have got on the original sample size calculation, so that by involving the 150, we'll make a good meaning out of our data. So we have to always balance this when we use finite population correction, because I see a lot of clinicians correcting their sample size and finally ending up with a very small sample size, which becomes irrelevant when we try to do further regression analysis and try to make a meaning out of it. So always try to consider that. And about the use of proper words in terms of research, for knowledge, you have used poor, good, right? Let's see your table. Yeah, so poor, good is not a good word to use. The other thing is, before that, you have interchangeably used awareness and knowledge. I am sure Dr. Solomon can reflect later on this. Awareness and knowledge, I don't believe they are the same thing. I don't believe they reflect the same thing. So it's better to stick to one of the proper terminology and not switch from one to the other. So I'm going to call it knowledge from now on. So for knowledge, good, poor is not a good term. Rather, it's better to use adequate, inadequate in any study. You know, like instead of saying poor knowledge, it's better to say that participant has inadequate knowledge about this particular subject matter. So replace that with that terminology. And for attitude, you better use favorable, unfavorable attitude. This is for any CAP study, okay? And here I have tried to extract the number. So this is your number. I have dropped it on the chat. 69.9% participants have good knowledge, 27.2 participants have good favorable attitude, and 34.8% are willing, and 12% took the vaccine. So when we study about willingness, willingness and practice are completely different things. We study about willingness when there is no chance to practice, right? So if the vaccine is not in the country yet, or if those study participants are not eligible for the vaccine at that time, we can assess their willingness. So when the vaccine comes, are you willing to take the vaccine, right? So if there's a chance to practice, if the vaccine is in the country, if they're eligible to take that, what was the rationale of assessing their willingness and not their practice? So for me, you should have used practice as an outcome and not willingness, because there is a chance to practice. So still willingness, at the end of the day, we want to know if they're going to get vaccinated or not. So if there is a chance to assess their willingness, it's better to assess their willingness. So, okay, I'm going to be fast. So on awareness, you have used only 4 questions, and these questions are not specific enough. It should be like more questions. Dr. Solomon has said it. And there are also very non-specific questions, general questions. Do you know about COVID-19? What's your about COVID-19? These are very specific questions that are difficult to assess specific knowledge about the vaccine. On attitude, you also have just few questions, like 5 questions, and you have used Likert, yes or no, but Likert scale is the better way of assessing attitude among participants. That's the right thing to do. Attitude should be assessed with a Likert scale. And when you see the questions, Dr. Solomon also can assist me here. Some of the questions are looks like knowledge questions, right? Dr. Solomon, can you see some of the questions? I mean, do you think COVID-19 vaccines are essential for us? Do you think we can decrease the frequency of COVID-19 without vaccination? Aren't these knowledge questions rather than attitude questions? There seems to be a mixture here, and a reason for COVID-19 vaccination hesitancy. Please take us to that table. Here also, these questions, yes. I am good, I'm in a good health, I don't need to be vaccinated against COVID-19. I expect this question to be in the attitude question. Why is it here separately? It looks like an attitude question, right? The second question also the same, the third question also the same. And, you know, and about, I don't know, most of the questions look like attitude and knowledge questions. So, but they're not included in the attitude and knowledge assessment. It's better to include them there. So I think you can take that. And the other is on the logistic regression, on your regression analysis, always mention the type, because there's no such thing as logistic regression analysis. Rather, there is binary, ordinal, multinomial logistic regression. So you have to be specific enough about which logistic regression you're talking about. And the others, perceived severity and susceptibility, are in the regression analysis, but they are nowhere in the description above. They are also within the conceptual framework, but in the descriptive analysis, they're not presented. And the other is knowledge and attitude are assessed in the model as both a summed up score and also a detailed question. For example, does COVID-19 really exist in Ethiopia? This is supposed to be a knowledge question, right, Dr. Ada? Dr. Ada? You can show us, right? So show us the next slide. So this is a very important point, because you have included awareness and attitude within your final model. So which is right, actually. So if knowledge and attitude are in the final model, the questions that are used to assess knowledge and attitude should not be parallelly included in the model, because, right, like this is what we call the issue of multicollinearity within a categorical variable. You have assessed knowledge, so you have used 4 questions to assess knowledge. So if you decide to use knowledge within the regression model, then you should use just knowledge, not the other 4 questions. They are already reflected within the knowledge. If you use awareness, attitude within the regression model, then the other 5 questions that you have used to assess attitude should not be separately included in the regression model, because attitude means those 5 questions. So here what we expect is knowledge, attitude, and the other socio-demographic variables that you have collected data on. And one last thing is variable selection criteria. Dr. Solomon also mentioned that if Deripsa is here, I think he's here, I'll give you a chance at the end to explain that. So univariate analysis is just a way of making sure that we decrease our variables to be fitted in the final model. And to do that, we use some cutoff points. But if we believe that our exposure variable is relevant and is worth controlling for in our final model, then we shouldn't remove it from the final model just because it fails our univariate or our variable selection criteria on the regression model. So I think Deripsa can explain on this. So I think it's definitely worth controlling for their age, especially for their educational status, their comorbid illness, because I think, I'm not sure if Dr. Hayat is here. She has conducted a study on COVID-19 vaccine acceptance among oncology patients. If you are here, Dr. Hayat, you can text us. So the COVID-19 vaccine acceptance seems to be very different among the general population, the healthy general population, and those with chronic medical illness. So that should have been controlled for, because it can show us a very interesting finding. So discussion, it's already mentioned, it's very important to first show the meaning of your findings, your major findings, and then you can compare it with other literatures, because at the end of the day, the rationale of doing researches, like gathering information from as many research as possible and creating an evidence from a meta-analysis or systematic review. So since we are going to be a part of some systematic review, showing it's the conformity of our findings with other studies is nice, doesn't hurt, but shouldn't be at the heart of our discussion. Our discussion should focus on the relevance of the meaning of the findings that we have found in terms of the existing knowledge and in terms of the study population characteristics. So that should be revisited. On the recommendation part, you have put some recommendations which are not result driven. For example, using social media platforms. I don't know about social media platforms, some designing programs. Yeah, those the last 2 findings are not result driven. We should always make sure that our recommendation is based on our result, which means what are the significant factors that affect our outcome. So if it says that willingness is affected by their gender, where there's nothing we can do, we can't modify their gender. So we can say that we can target more education and follow-up for, let's say, for the male, if that's where the problem is. But if we have modifiable factors from our analysis, we can target those modifiable factors and suggest something or recommend something. But when we do not study the effect of media or some other program on the outcome, on their willingness, we cannot recommend on those areas, because they were not studied at all, and they were not part of the regression analysis, and they did not show any significant effect. And lastly, on your main document, I have seen that you have some disclosure. So whenever you write a disclosure in a manuscript that you're planning to submit for a journal, there are many things that should be included. And it's important to look for the journal requirements of the journal that you're planning to send the manuscript to. So I have skipped the other parts covered by Dr. Solomon. These are my comments and suggestions. Thank you very much. I'll forward the other suggestions and comments raised by the audience. But in the meantime, if there is anything that you'd like to reflect on, let me give the chance for Dr. Aidan. Dr. Aidan, if you have a question, by the way, you can ask.
Okay, thank you for all of the comments. I will take it as a teaching moment, and I wish I had gotten this much feedback before. So I will accept almost all of the comments. And so on the sampling method, I use the systematic sampling method, and in an interval of 2 by dividing the total sample, the population to the sample size. And from the list of the drivers, I use systematic sampling method, and I only tried to do the research on bus drivers, on the 400 bus drivers. In the literature I used for the sample size was not a comparable, it was from the general population. And for the comment on the, if the ones who said they didn't have any information were considered, I didn't consider it before. So for the rest of all the comments, I will accept them, and I will try to correct for the ones I can. Thank you.
Thank you very much, Dr. Aidan. I'm trying to go through the comments raised by the audience. Most of them are, I think, already asked and reflected on. I will try to. Okay, about the systematic sampling. Okay. Oh, there's another question for us, Dr. Salamon, about you can see it on the chat box. So about the use of, I don't know, when you're desperate, you have to fight to make your study useful as much as you can. So if you fail to use a standard tool, if you fail to use some standard cutoff points, at least the least you can do is, once you have the data, you can assess for internal reliability, right? So my recommendation, I don't know if I've told you this before, any researcher should spend like 75% of his or her time on developing the proposal, because that's the stage where you can change everything, and that's the stage where you can manage to do the right thing. So once you've used a non-standardized tool, the base you can do is at least to check its internal reliability and see if it fits within the collected data at least. So doesn't mean that we're comfortable with the research outcome. I don't know who asked the question. Are you comfortable? Here's the question. Here's the question raised by one of the participants. Okay, I think Hayat, I think it's Dr. Hayat, the one that I mentioned about. Have you considered, have you looked for questions that might need reverse coding during analysis? So I think I can help her here. She doesn't have any questions that are measured on Likert scale. If it has, if the attitude questions were measured on Likert scale, and if her code was like from negative to some positive, negative to up to positive 2, and if the question has a negative connotation, she can use reverse coding to make sure that the highest values attributed accordingly. But she doesn't have any Likert scale, so this might not apply for her situation. Dr. Wandosan, is there any question that I have missed? Dr. Wandosan, can you please read on the questions that we have missed? Okay, so I think if we have missed, I think most of the questions are addressed, I guess. Yeah.
So most of the questions are actually addressed both by you and Dr. Salamon during your review of the paper. So I don't think there are missed questions.
Okay, thank you, Dr.
But there is one
Okay.
from one in the inbox who is asking for a final conclusion about the paper.
Okay, so Dr. Aidan can reflect on that. And in the meantime, we'll drop the post-test link, and you can still drop your questions, and we can collect on them. So Dr. Aidan, if there is anything that you'd like to say on the question, you can reflect that.
So on the conclusion, I concluded that the level of willingness was very low compared to the other literatures, and the significant factors that were associated with willingness were attitude, perceived susceptibility, and perceived severity. And I suggested that the media can use social media, and I did that because the main source of information was social media. So I also recommended for healthcare planners to create relevant programs and to provide trusted information.
I think that's great, Dr. Aidan. Yeah, the decision to say low, high, and other things, again, should be based on some set standard or criteria or some target at the national or international level, and not just with other studies. I mean, it can still be low as compared to other literatures, but can be a good number in terms of the national vaccine coverage target or some other things. So that's why we mentioned that on your conclusion and discussion, the findings should be given meaning in terms of the available scientific evidence and national or international policy and targets. So I think, Ripsa, are you around? Oh, I think okay, I think he left. Dr. Salomon, let me give you the chance to finalize and reflect on additional things you have. Dr. Salomon?
Yes, I'm
Okay.
I was muted. I could not mute myself. That's why I think a very enlightening discussion. Maybe a few remarks before we close. The first one is as a recommendation, and I suggest a formal a typical kind of message or education might not work in this situation. So what I'm suggesting is, if we want to educate those individuals, we need to craft a health message that is persuasive enough to show them that they're susceptible of acquiring, COVID, and also we need to show them that the disease could be severe enough to kill them. And these are the kind of message that we should be able to develop so that, the vaccine acceptance, their willingness could increase. So it's not just like any other form of education, like you need to go get vaccinated, the vaccination is important, whatever. That's not going to work. The best way we work is the messaging should be powerful and persuasive enough, addressing their vulnerability and severity. Okay, that's why we do this study. Now we know the factors now that are powerful enough to get these people get vaccination. So if that is what we're after, it's important that we come up with a health message addressing this important aspect, their susceptibility and severity. It's just like any other education. It should be something very well thought out. That is one important thing as a recommendation. The other one is I think I missed it and you've mentioned it. There is a kind of misclassification whereby some knowledge questions are in attitude, the attitude questions are in knowledge. There is a mix-up, so that has to be rectified. You've mentioned how that's this thing that we should do if we fail to find a validated tool for our study. As a remedy, we've talked about, the internal consistency stuff. But for me, the most important thing is, as a researcher, this is a platform that I would like to emphasize on. When it comes to developing questionnaires and tools for our study, that is what most students, graduates, put less emphasis on. I know we might not get a validated tool. You can go out and search for self-validated tool, you might not get it. It's common. Oftentimes we don't find it. But the problem with most of us here is that we don't really pay enough attention, sit down, think a lot to come up something, a tool, an item that could be as exhaustive as it can be, as valid as it can be based on our capacity. I'm not saying that whatever we would design some, a very powerful, valid tool, but have we put enough effort to come up with that strong and powerful, something close to validated tool? That's the point that I'm trying to mention. People give very, very little emphasis on it. Every time I look at a review of master's paper, the moment I go back and see at the annex, which is the questionnaire, you find lots of problems with the tool. Most you can see, it's easy even to pick up an information bar the moment I look at it. That's my problem. Now, I'm not saying that we need to come up with some strong validated tool, because you've mentioned that it requires a lot of things, that it has to be tested by itself. The tool by itself is going to be a study. There are people who work on their PhD and developing a validated tool. This shows that this is something serious. But are we putting enough effort to develop this tool? Is a question to every one of us. If we tried our best, if we give it the best shot, that's enough. And then we do the internal consistency test, and then that we're done. This is another important remark that I would like to comment on. And the strengths, Eden, usually when you mention your strength of study, you need to mention about the method, how robust, how convincing your study is in terms of your finding. That's what the strength of your study means. Okay, it's not something else. So you can talk about the design here, you can talk about the sampling, you can talk about the quality, whatever. Not that what you've mentioned there. All right. That is what I missed to mention earlier. All in all, this is a process that I learned a lot, and for sure, I'm not saying that we're teaching you here. Everyone is teaching for everyone in this platform. I always believe that I'm a big fan of social cognitive theory, whereby it states that learning could only happen through interaction, because every time someone talks, you begin to see a new perspective. So we're all in a making. We're all learning from this process. So this is a platform where everyone could benefit. And I would say not only the reviewers, so we're not here to teach you, me and myself, Tickers, but we're learning from each other. And I'm hoping that this kind of platform would continue, and hopefully that a lot of people are going to TG. Thank you so much for organizing this kind of forum. I'd like to thank Eden for being vulnerable. Benny Brown says that the vulnerability is a huge concept, that we all get scared of being naked in front of people, to be commented, to be out there, whatever we produce. And Eden is very, very courageous enough. Being vulnerable is being courageous enough to be out there, and she brings her great work for us, for every one of us in this platform to learn. And thank you, Eden. Thank you very much. Good luck in your career. TG, keep the good work. And the rest of you who are joining this tonight I know you're eager to learn, and I'm seeing lots of potential great researchers coming in the future to entirely change the research culture in this country as a clinician. And good luck for every one of you. Thank you for inviting me, TG. Over to you.
Thank you very much, Dr. Solomon. Yeah, very well said on everything, and we'll definitely take on the message and the remarks. Thank you, everyone. I think this concludes our session.